Welcome to this afternoon's Pathology session. I'd like to welcome all of you representing, I think it's 15 countries. We have 57 participants that have registered today. I see 24 have already joined the meeting. We have three interesting cases looking at drug-related liver injury. I'm going to hand over to Professor Cassinides to present the first case.
Thanks, Bilal. So the first case for presentation, in fact, I'm presenting it on behalf of a gastroenterologist called Dr. Fritz Potgieter, who practices in a place called Midstream, which is just north of Johannesburg, about 30 kilometers north of Johannesburg. And this is a case of a 29-year-old Caucasian male whose presentation was that of an acute pancreatitis in February of this year. It was well characterized, acute abdominal pain. The lipase was over 300, CRP was over 250, and imaging showed quite an edematous pancreas. The cause was obscure. There were no gallstones, no dilated ducts. The liver looked normal. But what was immediately apparent at the time was that the patient was deeply jaundiced, and his liver-associated enzymes, 2 days after presentation, he had a total bilirubin of 124 with a conjugated bilirubin of 76. The ALK phosphate was 248, which rose up to 614. Gamma GT of 360, an ALT of 122, and an AST of 41. Quite an intensive etiological search was made, viral hepatitis and a variety of other infections, which was negative. Bilharzia was negative. But of importance was, if you go back to the history, in December this year, he had, while slaughtering a buck, he had lacerated his hand. He required surgery, and at the time he received a variety of antibiotics, which were mostly penicillin-based, but also received a course of clindamycin and some anti-inflammatories and analgesics. If you go further into the history, the alcohol intake was kind of weekend and in binges, but he was a bodybuilder and had taken a variety of fast-acting androgenic and anabolic steroids, combining drugs, a combination of sustanon, trenbolone, decadorabolone, and dianabol. They're all these anabolic steroids. The jaundice persisted, the abnormal liver-associated enzymes persisted, and a liver biopsy was performed a few months after his initial presentation. He last took these anabolic steroids in October last year, and the liver biopsy was performed approximately 7 months after his last intake of these steroids. Martin.
Thanks, Prof.
Bilal, yeah. Bilal, do you want to see if there are any questions at all?
Yeah, let's open it up. Would anyone like to ask any further questions? I'm not sure if we can necessarily ask.
So I think the presentation clinically was that of a bland cholestatic hepatitis with some necroinflammatory disease. But the important thing is there were no features of extrahepatic biliary obstruction, and the degree of jaundice was really out of keeping with the height of the ALK phos and gamma GT on presentation, which clinically points, in my opinion, to an intrahepatic cholestasis. But it's open to the floor if there are any other thoughts.
So I think what is certainly good there is that the history did go back, not just the immediate history, but went back a few months looking at various antibiotic use. And for the fellows, I think it is important to go back at least 6 months in terms of a drug history to coordinate. And here it's sometimes a matter of a bit of police work, getting family members to contact the general practitioner and so on, and have a look and see what may have been prescribed.
Okay, Bilal, thanks. Just shall I show the histology?
Please go ahead, Prof.
Okay, right. All right. So thanks everyone, and thanks very much for asking me to present these interesting cases. So this is the biopsy that we received, and you should now see the screen. Bilal, can you see the screen?
Yes, Prof, it's up.
Right. Okay. So we've got I'm sorry about the various folds in the biopsy. It's just a technical artifact, but there was certainly good representation of tissue. And if we go through the H&E, you can see that we've got portal tracts represented. There were sufficient numbers of portal tracts to make it a representative biopsy. And going through it, you can see that in some areas, these portal tracts are expanded by fibrosis. There's also a mixed inflammatory infiltrate. So, for example, if we look at this here, we can see that there are predominantly lymphocytic infiltration, but there are also eosinophils associated with this as well. And bile ducts are here. The portal vein is towards the bottom half of the field, and hepatic arteries are also identifiable. So, for example, here I think you can see the hepatic artery there. So, bearing in mind that not too much is visible on that, and the history certainly is concerning. If we go down the biopsy, we can see that when we get drug histories, we always look at the central veins, and that looks reasonably all right. When we come to this area here, one can see that there is expansion, marked expansion of this particular portal tract. Now, I think one of the important things, that we're all taught is you have to say to yourselves, and you have to ask the patient, where have you been? What have you been doing? And those are two fundamental questions that we have to get from these patients. Now, this particular patient, as Chris said, was from north of Pretoria, in fact, considerably north of Pretoria. And those of you who are resident in South Africa will know that that's Bilharzia country. And whenever I see a biopsy, I always look to see where the patient is from, get the name and the address, and that gives you a fair bit of information that is not necessarily given to you, by your colleagues. So here we've got a patient then who comes from the Limpopo province. We've got portal tract expansion. We've got this mixed inflammatory infiltrate. I showed you a few eosinophils. And the first thing that comes to mind, certainly in this part of the world, is not drugs, but schistosomiasis. And when we look here, you can see that the inflammatory infiltrate is more intense. You've got greater numbers of eosinophils. For example, here and here, some of these eosinophils, in fact, are degranulating. And in some areas, one just gets the feeling, not 100%, but one gets the feeling that there could be a couple of epithelioid histiocytes. You can see the eosinophils there. You can see another eosinophil there, and another eosinophil there. Excuse me. So the question then, the next thing to look for is why are those eosinophils there? And has this patient got schistosomiasis? So look for hematine pigment. And despite a careful search, hematine pigment is not visible. And that's particularly important. And in fact, if I show you, perhaps I could show you just offhand what bilharzial pigment looks like. In fact, I've just shown a case at lunchtime, and I'll just digress to show you the sort of things that we're looking for. So this is another patient. This particular patient is from north of our borders, and certainly resident in both a malarial and a bilharzial area. And if we look, we can see this is a portal tract, and there is the pigment. You can see this bilharzial pigment is doubly refractile. And if you look in this particular portal tract, often when you're seeing patients with schistosomiasis, you just get these small little granules of hematin pigment, and you have to look for them carefully. And those of you who work in areas of where schistosomiasis is endemic, you'll recognize this sort of material. But you've got to look for that. And as I said, it is extremely subtle, and in many instances. So that's an example then of bilharzia pigment. So returning then to our patient. So despite the various searches and deeper levels, we were unable to find any bilharzia pigment in this. So then the next thing is, could this be drugs? And as you've heard, he's been taking an extensive or exhaustive list, in fact, of anabolic steroids. Excuse me, anabolic steroids. And when you go to the LiverTox website, and as we all know, the use of steroids and anabolic steroids typically in liver biopsies or in causes a fairly bland cholestasis. And this degree of fibrosis, in fact, is not reported in the LiverTox website. I want to show you, just go back to this area here, and there is an element of cholestasis. It's extremely focal, but if you look there, you can see this is a central vein. You can't actually see the vein. There's a little bit of fat, for example, a little bit of steatosis there. He has got this ethanol history as well, so that could be from that. But you can see here there's a bit of intracellular cholestasis, but it really is minimal. And certainly if we were to sort of look at this biopsy in other circumstances, we certainly wouldn't have thought of steroid-induced liver disease. However, there are reports of fibrosis being induced by anabolic steroids. And this is an example of that. And if I just stop this particular share and show you a couple of other things here, just go back to this. So here we've got, if I just increase this. All right, can you see that? So this is just
yes, we can.
slide. And here we've got a report that was published in the Journal of Pediatric Gastroenterology in 2014. And this was liver toxicity of anabolic androgenic steroid use in an adolescent male with non-alcoholic fatty liver disease. And you can see here, I've just extracted the relevant information. The liver biopsy was performed and demonstrated cholestatic hepatitis with hepatocellular and intracanalicular cholestasis, which we've got. It is mild. Portal and lobular inflammation, fibrous expansion of the portal triads, and an inflammatory infiltrate with frequent eosinophils and neutrophils. So that's one case report. And then this is this is actually a case that was presented, and it was a supplement that was published in the American Journal of Gastroenterology from 2019. And this is severely jaundiced bodybuilder. So the picture is exactly the same as what Chris has presented, a case of acute cholestatic syndrome with anabolic androgen steroid use. And this was from Chicago. And once again, you can see there's a liver biopsy, occasional eosinophils, mild portal fibrosis and cholestasis, suggestive drug-induced hepatotoxicity. Now, I don't know, can you see a whole picture here, Bilal? I'm not sure. Let me just minimize this here. Yeah. So if I minimize this, you can see the portal fibrosis that we've got in this particular patient. And if I stop the share here, you can see a picture which is very similar. In fact, and I go back to share this here. So you can see, for example, this fibrosis that is present, for example, here. you can see a very similar fibrotic picture. So I suggest, in fact, that this, as an example then of anabolic steroid-induced portal fibrosis, almost in South Africa, mimicking or masquerading as hepatosplenic schistosomiasis, which he obviously hasn't got. So this is steroid-induced or anabolic steroid-induced portal fibrosis. Thanks, Chris. And Bilal, I'm not sure if there are any questions on this.
No, that's a fantastic case, Prof. Thanks so much. Chris, did Fritz give you any update in terms of the outcome of the patient?
Yeah, so I mean, he conservative approach, and his liver-associated enzymes done last week, which are 6 months after the initial presentation and about a month after this liver biopsy was performed, showed a normal bilirubin with an alkaline phosphatase of 131, an ALT of 81, and a gamma GT of 169. So he's resolving very nicely on conservative approach, and obviously he's been told never to touch these steroids again.
Good luck to that.
Yeah, I mean, Martin, so just from a clinical point of view, this acute cholestasis, I mean, sepsis does it, and often patients who are septic are on drugs. You also see it in the in acute hepatitis A following the acute necroinflammatory phase. They go into this prolonged cholestasis. I mean, the histology differentiating these would be quite easy or not?
Yes, I think so, Chris. I know with hepatitis A, typically, as you said, you get necroinflammatory process with hepatocyte necrosis, and of course the cholestasis will be there because of the liver cell injury. And in hepatitis A, you usually find a few plasma cells as well, which is usually indicative, or certainly supports a diagnosis of hepatitis A. If you've got fulminant hepatitis in these patients. Obviously, in older patients, you've also got to think of autoimmune hepatitis as well. But and there's a relationship between autoimmune-induced disease with hepatitis A. It's an interesting relationship, in fact, between acute A hepatitis and autoimmune induction, which you see in children. That's been described in children, and in fact, which one causes which, it's not really resolved. So, but this picture here of portal fibrosis would be unusual in an acute fulminant injury.
And he was on a host of other drugs because, of the hand injury. He was on a host of penicillins, clindamycin, which can cause cholestasis. So the crux here is the portal fibrosis, which you wouldn't see in the other drug-induced liver injuries.
Yeah, correct.
Right.
Yeah, it's the portal fibrosis. Yeah, and I think that's and it seems to be a rare event. So the Liver Tox website doesn't report it, and it's only when you go searching into the literature, and you've got to put in those keywords to the case reports come up. So I thought it was interesting because schistosomiasis is endemic, as we know, here in South Africa and really throughout Africa. It's don't always jump into calling it schistosomiasis. Sometimes we have to make a presumptive diagnosis. And I think also the trick here, Chris, is he hasn't got portal hypertension. Yeah. Yeah.
So I think it's just important to note that this isn't the typical presentation of the anabolic steroid-induced liver injury. It's generally more a bland cholestasis that occurs.
Yeah,
and also
absolutely.
Biopsy hepatis, Martin, how common? That's quite rare, I think. Huh?
Yeah, biopsy is also one of the features of anabolic steroid use. And of course, the other thing that we haven't mentioned is the neoplasia. The hepatocellular carcinomas and the hepatocellular adenomas. Those are far more frequent, I think, than what we've seen here.
Yeah,
so
we had that gentleman that we transplanted a couple of years ago, Prof, with
right.
those multiple hepatic adenomas and one HCC.
Yeah.
Sia, your hand was up. Do you have a comment? we go.
Yeah, no, I just wanted to find out regarding the steroids. Was he then injecting himself, or was he injecting at his GP in terms of?
No, so it was a combination, I believe, and it's often the oral steroid that causes the liver injury, as opposed to the intramuscular version. Although, you know, considering the fact that a lot of these medications are illicit, you never quite know what's in them.
Okay, perfect. Thank you.
Yes, I must say, I mean, I was quite taken aback because, you know, when I got the biopsy and I saw, you know, because it was just on the form that, you know, his last sort of steroid use was a few months prior to the biopsy. I actually thought that was all iatrogenic, you know, therapeutic administration. It was only when I spoke to Fritz that you know, he says this is real, this is big stuff. And then I thought, okay, well, I need to pay attention to this, you know. And that it was only that, in fact, that then made me search for, you know, fibrosis, portal fibrosis induced steroids.
Shall we go on to the next case? It's 5-5.
Yeah.
Sure.
Mr. DP, is that who we're doing next? Yeah. So this is a 65-year-old gentleman with the metabolic phenotype, being diabetic with dyslipidemia, and unfortunately he landed up with SARS-CoV-2 in February 2022 and was admitted to hospital. During that admission, he underwent cardiac angiography and had a stent placed for an acute coronary syndrome. He subsequently became jaundiced, and on the 20th of June, his gastroenterologist in Durban did a liver biopsy for him. His liver function tests at the time showed a bilirubin of 195 with a direct component of 147, an alkaline phosphatase of 382, gamma of 183, ALT 195, and AST 171. Further investigations for viral, including CMV, EBV, and HSV, were all negative, and investigations for autoimmune disease were also negative. The current medications that he was on at the time included dapagliflozin, an SGLT2 inhibitor, metformin, aspirin, and clopidogrel. And I think he was on a statin as well. The biopsy was sent to us for further review, and I think, Prof, you did some good investigative work, so over to you.
Yeah, thanks, Bilal. So this is another fascinating case, and in fact, all these three cases, in fact, really just demonstrate how you've got to do that investigative work. But it also shows those of us who are histopathologists. You know, too often we sort of use the excuse and say, well, it's the biopsy is insufficient. And in fact, if you look at this, it just shows you, I mean, I would make two comments. First of all, I'm amazed how often histopath, in fact, in spite of the scanty bits of tissue that we get sometimes, that we're actually able to make a diagnosis. You know, it's quite amazing sometimes, you know, that you get a pleural biopsy, for example, and then sitting at the end of the small piece of tissue, there's a small epithelioid granuloma, which you can make a diagnosis of TB. And the same applies with the liver stuff. So here we've got a liver biopsy, and really, you know, in spite of everything we say, we've got, I think most people would sort of turn their, they'd say, no, I can't investigate this. But there's one portal tract, that's all there is. So we've got this here, and then we've got another tiny piece of tissue there, and there is the portal tract. And if we look at that portal tract, it's, you know, you may say, well, it looks as though there's a bit of periductal fibrosis there. But I think that often periductal fibrosis is very much in the eye of the beholder. So you don't really want to jump in and diagnose primary sclerosing cholangitis. So let's look then at the parenchyma. And here you can see, for example, just in the adjacent fibrous tissue, that there is a bit of a lymphocytic inflammatory infiltrate. There are a few neutrophils that are scattered around. So, for example, down here, you can see neutrophils. And then when we get into the parenchyma, you can see that there's quite extensive intracellular cholestasis, and there's also intracanalicular cholestasis. So we've got bile plugs in biliary canaliculi. There are also a few neutrophils and these foci of spotty necrosis of hepatocytes that you see there. And then if we go to this other portion of tissue, you can see, in fact, that neutrophils become more dominant. And there, for example, you can see a couple of neutrophils associated with this, and you've got these multiple foci of spotty necrosis. And here, for example, you can see greater evidence of cholestasis with these fairly large intracanalicular bile plugs, and then these foci of spotty necrosis. And when you see neutrophils, we always have to think of, and they're a good clue, because when you see neutrophils, it's basically drugs or alcohol. Okay, drugs or alcohol. And but you have to ask the question. So here, for example, neutrophils as well with spotty necrosis. But if you're thinking about alcohol, then you must also look for the other features of alcohol. And the important thing is steatosis, and there's no fat in this biopsy. I mean, look at all this extensive intracanalicular cholestasis. So if this patient, for example, I mean, one of the things that you'd automatically kind of think of is, well, could this be alcohol-induced acute alcoholic hepatitis? And the answer is, well, I suppose it could be, but, where is the fat? And there's no fat. And then you say, well, let's have a look and see if we can see Mallory bodies. There are no Mallory Denk bodies either. So what we've got then is a question of neutrophil-mediated cholestatic hepatitis. Essentially, that's what we're dealing with. So the next port of call has to be liver tox. And you go to liver tox and you read up all the information. And liver tox doesn't give you the required information. I can't remember what it actually says about the various drugs, but certainly atorvastatin, for example, this is not a typical picture of the statins and some of the other drugs. Now, the interesting thing is, the one that caught my eye is that some of these cardiac drugs. So, for example, if we think of skip my name on the tip of my tongue, the amiodarones, perhexylene maleate, those sort of things. Those drugs typically cause an alcohol mimicking pathology, which this is not really there. And we'll chase in lots of anecdotal stories about chasing alcohol in illustrious people who haven't consumed alcohol, and yet they have this alcohol picture. But this is not a typical alcohol picture. And anyway, by going through the literature and searching, what this is, in fact, is clopidogrel. And this is Plavix. This is a cause of Plavix-induced hepatitis. And if I stop the share here and go to another slide. So this is, now I don't know, can you see the full screen, Bilal?
Yep, we can.
Okay, so I can't see the top because it's partly covered, but this is case reports in hepatology. You can see it's in 2016, and here we've got clopidogrel-induced severe hepatitis, case report and literature review. And that picture there is almost identical to what we're seeing. So I suggest to you then that this is an example of clopidogrel-induced severe hepatitis. And notice that there's no fat. I mean, this is just these are sinusoids, but look at all these neutrophils that are associated with this. So I think it's I think it's a lovely example of Plavix-induced acute hepatitis. Over to you, Bilal. Shows you what you can see with a small biopsy sometimes.
No, well, I think
this is the only slide we got.
It's what's at the other end of the microscope that I think what counts.
Only with you, Martin. Only with you.
No, well done, Prof. That was some fantastic investigative work, and I believe the gentleman has done much better with the cessation of his clopidogrel. So he's improving nicely. On to our last case. Let me just open up here. So this is a Miss DM. She is about she's in her late 50s from what I recall. A general worker at a rural hospital, who was admitted in March 2021 with features of acute liver failure, having met criteria for orthotopic liver transplantation. She has a background of being hypertensive and diabetic, and both of which are somewhat poorly controlled. On presentation, she was found in ICU, where she was intubated on CVVHD and inotropes. Her initial evaluation, her virals, including expanded virals, were all negative. Autoimmune liver workup was negative, apart from an IgG of 20.03, with an upper limit of the normal reference range being 16. Wilson's, importantly, was also negative. Her liver-associated enzymes then, bilirubin total was in excess of 300. She had an albumin of 26. Globulins were mildly elevated, ALT of 884, AST 300, alk-phos 154, and gamma of 261. Steroids were initiated, and she made a mild improvement such that she was able to be extubated and gradually improve. And at that stage, a liver biopsy was performed. Over to you, Prof.
Okay, thanks, Bilal. So, I was just sort of getting the slides together. So you were talking about the first biopsy, the first admission, or the second? You're on mute, Bilal.
March 2021, Prof.
Okay, that's fine. So what we've got then is so this is the biopsy from March 2021, and I'm just going to put on the retic. And this is the retic. And I'm starting with this really to show you the extensive architectural distortion that is present in this biopsy. You can see all this reticulum collapse, and you can also see that is interspersed with foci of trabecular or hepatocyte regeneration with twinning of liver cell plates. And if I put on the mass volume is the Sirius red, and you've heard me talk about the Sirius red in previous meetings, you can see that there's extensive fibrosis. Now, you also had a biopsy in 2022, which we'll come on to. But first of all, let's go back to the H&E from last year. And it's a fragmented biopsy, but the reason for its fragmentation is because this was a transjugular biopsy. And transjugular biopsies are difficult to interpret because they fragment very easily. And it's also not helped by the fact that the patients who undergo transjugular biopsies usually have very advanced liver disease, which is why they're having the transjugular biopsy in the first place. And when they have advanced liver disease, they then are showing features of fibrosis and so on. And of course, you then get fragmentation along the lines of fibrosis. So, so that just it really doesn't help with the interpretation. So one has to have almost a sort of sixth sense as to what's happening in the parenchyma itself. So if we look at this, we can see, I've shown the architectural change, but you can see that we've got extensive cholestatic changes, intracellular cholestasis, we've got some feathery degeneration of hepatocytes, and we've also got this inflammatory infiltration. So this clearly is a severe cholestatic hepatic picture. And at that particular time, she was also taking herbal medication and for COVID-19, as I recall. Just see the date of this. Yes, so she was taking taking this medication. So the possibility then, and if we look here, we can see that there are expanses of hepatocellular dropout. So here, for example, you can see this quite extensive hepatocellular extinction, and difficult really to be certain exactly where that is. I think it's probably portal, because if you've got a bile duct there and you've got this extension here, I think this is probably zone 1 necrosis. So I think it's fair to say that with the history of medication, at least with herbal medication, that is probably toxin induced. There's also an element of bile ductular proliferation, which is part of the regenerative process. Okay, Bilal, do you want to talk, excuse me, the next presentation?
Yeah, so the patient was then discharged. She was advised specifically to stop her herbal medication. She was taking Artemisia africa, a traditional medication known as an immune booster. She was discharged and on a bit of steroid, came back to clinic in June 2021 with an almost pristine LFT. In fact, the only abnormality on that LFT is a gamma glutamyl transferase of 116. Her ALT and AST were both 20 and total bilirubin of 7. Unfortunately, I suppose it was the fear of COVID was a bit too much for her. And in January 2022, she represented with a 2-week history of jaundice, nausea, vomiting, and diarrhea. And a liver biopsy was repeated at that stage.
Okay, thanks, Bilal. So this then is the biopsy then that was done this year. And here you can see that the pathological changes are very similar to the previous biopsy. And in fact, I think that this particular biopsy shows the pathology in better detail compared to the previous biopsy. So here you can see, once again, this reticulum collapse. You can see that there is bridging necrosis. For example, if we look at this here, you can see, I think this is probably a portal tract here, you've another portal tract here, and then you've got this extensive bridging collapse and hepatocyte extinction. And then in some areas, there is certainly a suggestion of nodularity, which is starting to come through, and one can see twinning of hepatocyte plates. So certainly this is at least an F3 picture, and in fact probably is closer to end-stage cirrhosis. You can see this here as well, extensive twinning of hepatocyte trabeculae. Moving to the serious red. You can see now that this nodularity is a much better stain than the previous case. But you can see the extensive fibrosis. You can see the bridging that's taking place, for example, there, almost complete circumscription, for example, of that regenerating focus of hepatocellular tissue. And then if we go to the H&E, we've got changes that are, if anything, more pronounced compared to the previous biopsy. So what we've got, so that's a portal tract, and you can see that there is this inflammatory infiltrate in the portal tracts, relatively mild, lots of bile ductular proliferation, but the dominant change in the pathology is present in the hepatocellular parenchyma. And if we look at that, we can see we've got this extensive feathery degeneration of hepatocytes, ballooning of hepatocytes, abundant intracellular cholestasis, and then there are multiple foci of neutrophils. And you can see here, for example, that we've got neutrophil-mediated injury with this ballooning degeneration of hepatocytes. I think I've got to focus here. Yeah. So there, we've got this balloon, at least we've got that picture there shows you this extensive ballooning and this focus of neutrophils here. So we've got neutrophil-mediated hepatocyte necrosis and more there as well. But notice that there's no evidence of steatosis in this. We've got cholestasis, which is showing you the intracellular cholestasis. We've also got intracanalicular cholestasis as well. So this patient then was taking this medication again. Medication, in fact, contains, it's called African wormwood, and it's the local variety, in fact, is Artemisia afra, and that's interesting thing is if you go through the literature, it has been used in a, well, put it this way, it's been suggested as an investigator for a possible use for HIV, for the therapy of HIV. It was also proposed as a possible herbal remedy for SARS-CoV-2 infection, which is probably why she was taking it. And I think that Artemisia afra, as I said, is a possible cause for this injury. So interesting case. The local name, please forgive me if I pronounce it incorrectly, but it's Umhlonyana. Have I got that correct?
You're close enough, Prof. It's Umhlonyane.
Okay, thanks. So I don't know if there are any comments on that. Certainly going through the literature seems to be mixed. There's not much on it from the point of view of hepatotoxicity.
So I know the Cape Town group have also had a few of these cases present to them recently. I know Mark Sonderup presented a case of this at the recent SAGES conference. So I think this is something for all of us to be increasingly aware of. I think this route is found throughout Southern Africa into Madagascar as well, where at one stage it was being touted as a possible COVID cure. I think the government of Madagascar were looking at pumping money into exploring it.
Yeah, it's interesting because yeah, it's interesting, Bilal, because it is part of Artemisia, the sort of broad group of Artemisia compounds, and the fact that we're using it, for example, for malaria, is it's one of the compounds that came out of China as a result of the investigation of local remedies. So yeah, it's interesting. Much more work to be done on it, I think.
Yeah. I see Mzama's got a question, and he's asking, in general, what proportion of patients with drug-induced liver injury, particularly where there is some fibrosis, will progress to advanced fibrosis, cirrhosis, versus regress, even when the presumed offending agent has been removed. Anyone want to hazard a answer to that, or can I have a go? So Mzams, I think it does very much depend on what agent is involved. Different drugs have different sort of metabolisms and enterohepatic circulation, and different mechanisms of injury. As Prof was talking about a little earlier, you have some drugs that initiate an autoimmune hepatitis type picture, and that, once initiated, can continue and progress despite the withdrawal of the offending agent. And this is where you need to be careful with your steroid script and steroid withdrawal in these sort of patients. I don't think I've got an exact figure in terms of overall what what sort of patients will progress on, and I do think it is somewhat more individual. I don't know if anyone else has any further comments on that.
So, Bilal, I mean, what I can mention is I was just reading up about some of these drug-induced medications, and I came across quite a frightening figure, in fact, and that is that in Europe, 200,000 people a year die from drug-induced or toxic liver injury.
Sure.
Yeah.
I wouldn't have thought it as high as that, but it was 200,000 a year. Yeah.
Well, I think you only need to look at the misinformation that has occurred, and I think the whole COVID and mistrust of medical science is going to just increase medical skepticism and scientific skepticism, where people are going to be looking for alternate cures and are going to be more open to using complementary and herbal medications, which are not necessarily put through as rigorous testing as traditional pharmaceutical agents are, and that's a significant concern. Badruddin Yusuf has thanked you for the fascinating presentation, and he's asking, are there any features under the microscope believed to be indicators of good prognosis?
Or in fact, bad prognosis too, Martin? What would alert you that this might progress?
So I think, as Bilal has said, certainly, if it's autoimmune, then you've got to be careful. The other thing as well, drugs that, for example, if we think about the chemotherapeutic agents, if you have perivenular thrombosis, perivenular necrosis, those sort of drugs, if you've got a sinusoidal obstruction syndromes, I think that those can be progressive into the future. And then, of course, we mustn't forget about the vanishing bile duct syndromes with things like antibiotics. And, some of the things that we've seen over the years have been, it actually makes you think, should you be I mean, we, as practitioners, we kind of dish these drugs out with gay abandon almost. Numbers of patients, for example, Bilal, you recall patients on allopurinol with vanishing bile duct syndrome, patients on antibiotics. What's the word that I'm just trying to think which is the one that causes the vanishing bile duct?
Augmentin?
Augmentin, yeah. Another one, Augmentin is dished out like sweets. And some of those patients will go on and end up with liver transplantation, but some will recover. The other one that is also quite frightening is ketoconazole. People with nail infections, fungal nail infections, they're given oral ketoconazole, and we've transplanted a couple of patients with end-stage liver disease secondary to that. So I think one has to be very careful. And I think as far as prognosis is concerned, I think once you start to get fibrosis, then you've got to be careful. And of course, monitoring patients, you've got to monitor patients. If they're known to have hepatotoxic causes, then one should do liver function tests. But Bilal, you know more about that.
Yeah, no, absolutely. We've got a few minutes left if anyone else has any further comments. So yeah, go for it.
I've been seeing a couple of cases in Barra where patients come in. It's usually a cholestatic LFT, and some of them have just been switched, let's say in the last 2 or 3 months, from efavirenz to dolutegravir-based regimens. Are you seeing a spike in the number of DTG-associated DILIs, and do they have a specific pattern?
Not here. We haven't seen too many of those yet. I know DTG can cause a liver injury. I'm not certain about the exact pattern. Have you looked it up on liver tox? Is it fitting?
I haven't found a lot on the literature. It doesn't look like.
So in terms of, I mean, what I was going to actually close the meeting with was just a couple tips for the fellows, in that when you're confronted with a patient where you've done an extensive workup in terms of viral, autoimmune, you've considered possible genetic causes for liver injury, and your workup thus far is negative, a drug-induced injury needs to filter towards the top of your differential. And that's where I was saying, it's important for the family to get involved, go back home, go look at all medication. Or some people don't take the supplements that they're using as medication. Some people will say, listen, I'm on green tea extract, but that's natural, and they're not going to tell you about it. And you're going to need to make sure that they understand that you want to know about everything. All right. And often you can tell a family member, go home, just empty out all medication into a bag and bring it to me. This is something that we have done in the past, where we then can pick up exactly what has been used in quite a lengthy time frame. You're talking about that 6 months prior. There's then once you've got that, my advice to you is, when you're considering a drug-induced liver injury, access the Liver Tox website. The Liver Tox website is an invaluable tool. We had the pleasure of hosting Jay Hoofnagel not too long ago. He's a good friend of Professor Cassanides, and this is one of the brainchilds of Professor Jay Hoofnagel at the American National Institute for Health. it is a repository of all case reports of liver-associated injury attributed to drugs. It gives you a fantastic breakdown in terms of what is the mechanism of injury, what is the what are the treatments, what are the outcomes, etc. And can break it down in terms of various other options as well. So if you are thinking about DTG, it is as simple as typing DTG into Google along with liver tox next to it, and it'll take you to the page where I have just done it now, and I can tell you that it has not been linked to instances of acute clinically apparent liver injury. So yeah, you may. It does also give you a likelihood score associated with it. So yeah, that's how I'd recommend you work through those cases.
Okay.
Okay. Anyone else?
Thanks, Bilal. Perhaps I could just mention that, I mean, obviously there are some drugs where the reactions are predictable, but there are also many where it's completely idiosyncratic. So if we take that clopidogrel one, there are lots and lots of patients who are on Plavix who don't develop, drug-induced injury, but and it's vast majority. But one needs to look at those and see. As soon as the LFTs go up, then you've got to look at the drugs. But liver tox is an excellent site.
Yeah. Anyone else have anything further? Before I close, I see we had just over 40 individuals join us. I'd like everyone to please have a look at the link to give us feedback on these sessions. Let us know maybe if there's something that you'd like us to potentially cover in the future. Professor Hale, thank you so much for your time. I'd like to thank the ECHO India team for their assistance with running the backroom detail. And obviously the Gastro Foundation for making this possible. I think next week's meeting is on HCC, where Prof Ed Jonas will be chairing a meeting looking at unusual presentations of hepatocellular carcinoma.
Thanks very much, Bilal. Thank you, Martin. Excellent as usual.
A pleasure. Thanks for inviting me. Thanks, everyone.
Thanks, everyone.